So I'm just within the next 10 to 15 minutes or so, I'll try to summarize some of the work that we actually done on telemedicine and how we actually can optimize care and with a particular focus in Ramadan fasting itself. So I guess I would perhaps, or most of you would have already heard this over the last day or two. So that diabetes is really a global health problem itself. And I pulled this off recently from the IDF Global Atlas itself. And if you look at this particular map, I think that paints 1,000 words in the sense that if you look at it, the diabetes prevalence is a global health problem that has been increasing year on year itself. So when I started off doing a little bit of work or a little bit of research on diabetes itself, the global prevalence at that time was about 339 million. And by 2021 itself, it's already 537 million. So that's a staggering 200 million increase in less than about 5-10 years ago. And this statistics was just pulled up. But if you, it's like you throwing a stone. If 1 in 10 patients itself will have diabetes or are diagnosed with living with diabetes, and this number is again predicted to rise even higher to 643 million by 2030 and 784 million. And unfortunately or fortunately itself, if you look at these numbers, a lot of them, about 3/4 of them, of people with diabetes actually live in low and middle income countries where, for example, where Malaysia is itself. And if you think about the effects of diabetes, I think I'm sure a lot of you will know that it's actually caused a lot of death and it's actually a very, very expensive affair. And when I actually tried to delve deeper into the countries and into the prevalence, that was, if you look at it, Muslim majority countries account for nearly 1/3 of the top 10 countries with the highest diabetes prevalence itself. So if you see that this is really a big problem itself, really in the Middle East, in some of these Polynesians and countries itself, but also in Malaysia itself, where diabetes prevalence is really very, very high. And I guess, thank you for attending this. And also, I guess everybody, as we have heard from our previous speaker itself, that fasting is really a main pillar of Islamic faith itself. And for many Muslims itself, they will choose to fast. So I think earlier we heard from the study itself about 9 in 10 will actually have an intention to fast, irrespective of whether it was COVID or not. And we have also heard that, there are many exemptions given, but most of people, even in the epidemiological studies, suggest that a lot of Malaysians who have type 2 diabetes intend to fast during Ramadan despite being exempted for. And we know that, when you have a fasting, a lot of them actually have an increased role or risk of hypoglycemia itself. So that really became a problem for a lot of people. And as I was speaking to some of the clinicians and also some of the primary care physicians itself, where I work a lot of it, that became a problem. It was a problem for them, but it also became an opportunity for some of us where we work in academia, because that became an opportunity for us to try to improve the healthcare system and try to improve the public health messages in it. And so one of the first steps that we actually started off before we actually did a study was actually, we actually ran a systematic review on studies conducted for Ramadan for type 2 diabetes. So we actually searched for 3 different databases, and what we found was that really there were very, very few studies at that time. There were about 12 studies only found, and that was way back in 2016. And so but what we did find was that it was actually a very, very reassuring message for us, was that a lot of us, it is possible for type 2 diabetes people to fast safely during this period, and the risk of hypoglycemia was only increased by approximately 6%. Now, there are some caveats to this itself. If you really look at it, is that, during this, when you actually do this, you have to give them diabetes-related education. Some of them actually change, and a lot of these studies were actually switching the hyperglycemic, the drugs that are oral hypoglycemic agents that tend to cause hypoglycemia. So the most common for all the sulfonylureas, they actually change them to compare them with the newer anti-diabetic agents, for example, the SGLT2 and the DPP4s itself. But what we actually found really very interesting was that there was no randomized controlled trials looking at the roles of education as well as non-pharmacological therapies combined together, or non-pharmacological therapies combined together. And I guess from that, an insight was that, it was a very, very challenging study design, I guess, because recruitment was, you had this really very small recruitment period where, you have to recruit them just before Ramadan, follow them up. And then because if you miss the boat, you have to wait a full year or so before you get the next cohort of people who you can randomize and recruit into your study itself. But it also presented for us a very unique opportunity for us to conduct a study in Malaysia, because I guess in Malaysia, as I've mentioned earlier, there were quite a number of people with type 2 diabetes itself. And so one of the things that we have dwelt in was the use of telemedicine, or very broadly defined is the use of medical information from one site to another via electronic communication. So we at that time were looking at using some form of mobile apps, or even an SMS, or even a Bluetooth glucometer. So that was the aim was actually to avoid or prevent or to address this logistic barrier that actually had, because a lot of people, I guess as clinicians, you may know that a lot of them actually don't come back for your follow-up. So one of the things that we tried to do was whether we could actually bridge this logistic barrier or not, where we could instead, if you don't want to come to us, never mind, what we will do is we will come to you and offer you an alternative and try to treat you as best as possible. And so the aim was actually to provide a wider access to medical care and expert medical advice. So that started off sometime in 2015, 2016, where we actually started off to build an interactive platform to enable practitioners to monitor, to intervene and to educate their diabetic patients using a fast and interactive way. And that's where you could actually provide regular updates and platforms itself. And so what we actually did was we actually started off a very small pilot project. We termed that Mr. Fast, which was actually the acronym for making Ramadan fasting safer for people with type 2 diabetes using technology itself. So our aim was we actually were really looking into whether telemedicine or even using some form of technology can enhance the management of type 2 diabetes who were fasting during Ramadan, and also to assess whether if we gave this small little web-based glucometers during Ramadan, will that actually help improve monitoring or not? Because I think if you had attended the earlier session, I think one of the speakers actually mentioned that a lot of patients actually were hyperglycemic. They rarely monitor during the Ramadan period and even during non-Ramadan period itself. So what we wanted to do was that, look, if you had this little glucometer that we could send messages which were interactive enough, would that be impact us and also spur the people to actually improve and monitor a little bit more? So we actually conducted this over 5 clinics in the Klang districts where we provided them with baseline educational counseling itself. So it was sort of like a prospective randomized controlled study where we actually recruited patients with type 2 diabetes who were fasting for at least 15 days. So we sort of split them into the usual care versus telemedicine. And what we did was we actually developed new health modules itself, where we actually developed new curriculums teaching them about diet, teaching them about what would you do if you experience some hypoglycemia? How do you regulate your sleep patterns, etc. We also actually provided or tried to assess some form of physical health data to encourage them to see how many steps they actually walked, as well as also food diaries, where we actually encourage for self-monitoring. We track their blood glucose, their weight, to see how they actually progress during the Ramadan period. And also we had this little chat function where a lot of patients, they actually had very, very small questions. I think as you have heard earlier on, a lot of them were actually very concerned that, if I actually tested for my blood sugar during Ramadan period, would that invalidate my fast? And so we had these small little chat functions where we could actually explain to them and then get them the advice itself. Or perhaps, they said, oh, look, I missed my dose because I just woke up late. What should I do itself? So little things like that. We actually had this chat function available. So what else did we do? So it created this nice little interface where you could see how many steps you've walked, how many calories you burned, how many sleep, your heart rate, but also a little chat function, as I mentioned, as well as the sugar levels. And that itself was available to the patients, but as well as the clinicians, where they could say, oh, look, in this particular patient, the sugar levels were dangerously low. And then what would happen is that we would then communicate with the patients to speak to them to see whether, what we could help and support them in this sense. And so we actually sort of randomized 37 patients with 29 patients who completed the study. And we actually looked at we found that metabolic control was really better during Ramadan in the intervention group, with fewer patients reporting hypoglycemia. So if you look at it in terms of symptomatic hypoglycemia as well as self-reported hypoglycemia, these were really much lower in the intervention group. So we thought, oh, that's really an interesting thing, because but as with a lot of studies, when the numbers are really small, we thought that look, it may not really provide a true picture itself, and then the intervention was really short. So what we tried to do is we reran this particular study again in a larger cohort, about 85 of patients 2 years later on. And what was very reassuring in our study was that we actually found that a lot of patients, in terms of symptomatic hypoglycemia, it was lower. So it was much lower during Ramadan, as well as in terms of confirmed hypoglycemia. So you had fewer patients who reported hypoglycemia during this period. We also noted that in terms of HbA1c or in the glycemic control, this was much better with the use of telemedicine, as well as and so one of the things that we also thought is that look, when we actually ran the intervention, telemedicine may not be really something that is suitable for anybody and everybody itself. So what we did was we also tried to listen to the patient's voice itself and ask them whether what are your experience using this particular device itself, whether what do you like about this, what was the problem itself. And very reassuringly, I think I'll leave some of these quotes here, but I want to read to you the first one, which is said that, which really got us a little bit shocked, was that, I have never used this glucometer. I never used a glucometer before. So in this particular patient, they have never used a glucometer until they actually enrolled into this particular study that we held. And they actually found that actually glucometer actually helped a lot. So what they used to do, they used to guess the glucose levels. And so one of the things that we found out was, look, it's really very useful. But again, when you actually select your patients for telemedicine, I think you have to be very careful who you select with, because some people actually prefer not using a device itself. So we also had a lot of patients who came back and tell us that, look, the glucometer was really great. Every function was great, but the font size was really very small, because we are sort of old, so we prefer if we have something physical where we don't want to rely on our phones itself. And also there was quite a fair bit of barriers itself when you learn to operate this. So one of the key lessons, I think, just to summarize, if I may within the next minute or so, is that for me, telemedicine potentially can be a very useful tool itself for a lot of us, especially during Ramadan period, because there is only a limited amount of physicians and clinicians available, but there are many other patients with type 2 diabetes. As I mentioned, there are 500 million versus only a handful of you itself who are willing to treat the patients with diabetes during Ramadan. And so when you look at it, I think telemedicine or the use of digital health is really a very big potential itself. But then again, when you actually do it, one of the things is that you have to select your patients who will benefit the most out of it. And I think from some of our learnings itself, there is some benefits of using telemedicine, but these will be likely to be the younger populations, around 40s to 60s. These are the ones that will benefit a very fair bit more versus those who are older, because when we actually spoke to the older ones, they actually tend to want to speak to the clinicians. They want to have the personal touch itself. So I think that's a little bit short sharing about my work itself. So I just would like to thank everybody from who were involved in this study, as well as my PhD students and in the funding bodies that funded this project itself. So thank you.